Welcome back to the Canadian Concussion Center's webinar series. If you've been with us before, we've just been on hiatus for the summer, and so this is our first week back. My name is Leslie Rattan, and I'm really pleased to be moderating our series, which was developed for individuals that are struggling with symptoms of concussion, their caregivers, and healthcare providers as well. And our sessions focus on various aspects, symptoms of concussion, and we typically we've got expert speakers that will do a presentation first, and then that's followed by a question and answer period. And the sessions right now are going to start recurring every other week on Tuesday evenings from 6 to 7. And if you want to go back to watch any of the previous sessions, you can actually find those on the Canadian Concussion Center website. And Christian has very kindly just put the link to that in the chat, so you can find it there. For this evening's session, if you have any questions, if you could put those into the Q&A, you'll see a little tab at the bottom of your screen. If you just click on that, you can enter any questions that you may have for our speakers tonight. If you're having any technical difficulties, if you could enter those into the chat, and Christian can give you a hand there. We are just going to run a short poll. It's always very helpful for us just to get a sense of who is in the audience. So I'll just have Christian put that up. So I'll just give you a second to do that. Okay. So for this evening's talk, I'm really pleased to introduce both Doctors Michael Hutchison and Dr. Richard Wenberg. Dr. Hutchison is going to be doing the presentation tonight, and we're really pleased to have both Dr. Hutchison and Dr. Wenberg, who will be available to answer any of your questions. And as you can see, the title of tonight's talk is Return to Athletics. So just a little bit about our guest. Dr. Michael Hutchison is an associate professor and director for the Center for Sport-Related Concussion, Innovation and Knowledge at the University of Toronto, where he oversees an interdisciplinary clinical research team of health professions for sport or physical activity related concussion. He holds a PhD in rehabilitation science and is a registered kinesiologist. And present research focus is in the areas of neuroscience, kinesiology, and rehabilitation. He also holds scientist positions at Keenan Research Center for Biomedical Science of St. Michael's Hospital and the National Hockey League Players Association. Michael's research productivity is internationally recognized with over 80 peer-reviewed publications and has received over $6 million in funding, including principal investigator grants across all Tri-Council funding bodies. Michael is also the founder of Rhea Health, Inc., a University of Toronto health technology that uses evidence-based physical movements tailored to assist in the recovery of concussion and mental health conditions. Dr. Wenberg is a professor of medicine, neurology, University of Toronto, director of the Clinical Neurophysiology Laboratory and Mitchell Goldhar Magnetoencephalography Unit at the Krembil Brain Institute, Toronto Western Hospital. And he is involved in sports concussion research and clinical care and a member of the NHL and NHLPA Second Medical Opinion List. He's the author of over 200 scientific articles on topics ranging from the nonlinear dynamics of brain function to the effects of ice surface size on hockey injuries. His principal research interests relate to the biophysics of electroencephalography and MEG, including application of these techniques to the study of concussion. So with that, I'm going to turn it over to Dr. Hutchison.
Great. Thank you for the introduction, Leslie. And welcome everyone this evening to our webinar on Return to Athletics. We have done this before, so this is a second go at it with Dr. Wenberg and I. And really, I just want to use the initial presentation of maybe just setting the stage on some general, groundwork and understanding, but hopefully be a catalyst to have some reasonable conversations and question and answer, because I think that's usually the most fruitful time where your questions can be explicitly answered and we can have some reasonable discussions. So just to kind of get into it here, as has already been identified, my affiliations, but nonetheless, they're up there on the screen. And also just acknowledging a potential conflict or commercial interest with REA, the digital health platform for concussion rehab. It does maybe come up in one slide, so I think it's important that I acknowledge that potential conflict. Here is a slide just kind of giving you a little bit of an idea of what we're going to talk about for the next little bit. The main thing here is that, setting a concussion primer, I really want to set the stage to make sure we all have a full understanding, or at least we're all on the same page. Talk about acute management, and these are very high-level discussions. And then we'll get really into athletics. And first, I think we have to acknowledge or identify what's really unique with sport. And when you return to athletics, what are those considerations that need to be thought of or at least recognized. And with respect to concussion management and return to athletics, we will kind of go through those stages, and it is a progressive kind of stage progression, and so we'll go through that, and then hopefully the enjoyable part for everyone, we'll have time for Dr. Wenberg and myself to do some questions and answers. So I will be sure to leave enough time for that. So, as understanding concussion, I often use this kind of pictorial to set the stage. I find it quite useful. I think, concussion is multifactorial. As much as we understand the trauma of concussion, whether someone falls and hits their head on the ice, or whether someone's playing basketball and they get an elbow to the head, or even something like volleyball, where someone spikes the ball and they get smashed, called smashed in volleyball when the ball hits them in the face. There's obviously this rapid acceleration of the brain within the skull, which we know as concussion as a neurometabolic cascade. Now we know that there's ionic fluxes, there's changes in blood flow, and those things are one item for sure. And that's really central to what we understand concussion to be. But when we manage the person, the individual, we have to recognize that there's various components to it. At central, yes, there is the neurometabolic crisis of concussion, but there's also comorbid issues. And what we mean by that is that there are also things that happen to the individual at the same time as a concussion. And most often when we think about this with respect to concussion, comorbid issue that most frequently occurs is neck-related injuries. And obviously, if we appreciate what happens to the head when it's hit or struck, or when someone falls, there's potentially mechanical trauma to the muscles, the ligaments, and tendons, all associated with the neck. So we have that kind of central concussion in the neurometabolic cascade, and then we also have potentially disruption, or I'll put in quotes, abnormalities that also occur at the same time. That's more, sometimes the neck, more often than not, but it could be other injuries as well to lower or the other extremities. But we do know that what we're saying is that something also happens at the same time. So then you have, maybe potentially similar symptoms, headaches, maybe difficulty with balance. Both of those can be contributing by both, whether it's the concussion or maybe a neck injury. And that's important from understanding as a clinical perspective. And then we have what I refer to as premorbid issues. And what we say to that is what the individual brings into the moment of the injury also contributes to things. And so what do we mean by that for concussion? Why is that important? Well, there are certain kind of factors that contribute to certain clinical presentation, or whether or not we understand it may take a shorter or longer duration of someone's recovery. And for example, a lot of common discussions in the concussion space is, do more concussions result in certain issues, greater severity, longer recovery? But if someone's had one concussion historically, or someone's had 5 previous concussions, that may be something to consider. The other things to consider is, does this person have a pre-existing sleep disorder? Do they already have maybe trouble resolving that neurometabolic crisis because they can't rest? Do they have other issues or maybe around anxiety or depression? These factors can also contribute to that in the moment, a few days after a concussion, their clinical presentation. And so really you start centrally, yes, at the concussion, but you also have to acknowledge comorbid or premorbid issues that in the end, in totality, results as a patient in front of a physician or any healthcare professional after suspected concussion. And I think that's important to recognize. The other piece that's really important to recognize from this is that means that, the same diagnosis of concussion can have very differential situations of how they present based on all these factors. So one person can have no comorbid issues and no premorbid issues. But another exact same person diagnosed with a concussion can also have a comorbid neck injury, have a history of anxiety, have a history of sleep disorder, and maybe even have migraines and going into this. And so that's a very different potential clinical presentation, and that may actually require different healthcare professionals in helping getting them on that road to recovery. A couple other things so we can level set everyone. Concussion primer. Let's take memory, for example. In the sporting context, most people have full memory of the event and complete recollection before and after. So what we're talking about is whether they have amnesia before or after, or loss of consciousness. If you look at the published reports on this, approximately less than 10% of people lose consciousness, and roughly about 20% would have some amnesia. So, the reality is most people have full recollection of the event. Symptom onset. This one's really important, and sometimes clinically this can get a bit gray in understanding. Is it a concussion? Is it something else that potentially is contributing to their clinical presentation? The diagnosis of concussion requires two things, really. An event, and the event that I'm referring to is the rapid acceleration or the trauma to the head, or that's one piece. And then the other piece that's required to make the clinical diagnosis is either they have to have symptoms or they have to have behaviors that someone can see, visible signs, in relatively close proximity to the time of the event. This is most often a little bit troublesome for clinicians with symptom onset. So for example, if I was to fall in my chair here and hit my head on the floor, I would expect that I would feel unwell relatively soon after that. It may not be right now because I'd be maybe embarrassed and kind of be a little bit excited, and I'd probably get through it. But maybe after, if I was to go watch TV in a couple hours from now, and I'd realize, oh man, I'm having trouble watching the TV, my head's starting to hurt. The close proximity is like, a couple hours from that. Now, if I fell off my chair and hit my head on the floor right now, carried on with the presentation, maybe have red face, a little bit embarrassed, have no issues. And let's say, a week from now, I start having a headache and I have difficulty concentrating and then I can't watch TV. That's a long period of time from that falling off from the chair. And so we want to see symptom onset to be in relatively close proximity to that suspected event. And we recognize it can evolve over time. And usually we expect about 24, 48 hours for that temporal sequence to occur. Standard imaging, if you go to a hospital in a suspected head injury, they're not diagnosing concussion. They're ruling out that you don't have a more severe injury. And so there's not going to be anything that tells you whether you don't have a concussion if you end up in a hospital and they do a CT or an MRI in standard kind of neuroimaging. Now, there's more advanced techniques that may be helpful, but current practice, that's not the case. Recovery, when can one expect to recover? And generally in the sport context and returning to athletics, we see most people recover within 3 to 4 weeks. I'm using that number as a very kind of crude estimate for someone between 18 and 25 years old. If they're a little bit younger, that seems to be a little bit longer. And if they're professional sports, that's actually a bit of a faster recovery. But generally speaking, safe to say that by a month you should be okay. Now, we do know that a subset of people can actually have symptoms for a much longer period of time. And that we refer to those people as people with persistent symptoms. And upwards to about 30% may have symptoms past a month. And then the minority, 10-15%, may have symptoms greater than 3 months. This kind of temporal sequence of events here in terms of recovery has been replicated in university sports, professional sports, youth sports, but these are decent estimates to understand that most people in the sporting context recover in a couple of weeks. Unfortunately, a number of about 30% recover more than a month, and then this kind of smaller percentage, 10 to 15%, recover greater than 3 months. So hopefully those are some helpful numbers. So I want to kind of give you a little bit of idea of what are generally accepted acute phase principles. And so when I'm talking about acute phase, I mean in the first 24, 48 hours, 72 hours. What should someone do as soon as they've been seen by the physician, they've been diagnosed with a concussion? And rest still, even though I have in brackets there, rest is important for at least 24 to 48 hours, and education. I'm going to start with rest for a second because I think that's the one that seems to have gives people the most trouble in the real world. Is that rest means don't do anything, go to your room, lock yourself in, do not socialize with the world, and that's not exactly the best approach. It's relative, so what I mean by that is if you don't have any trouble watching TV, but you have a bit of a headache, it doesn't mean you should just turn off TVs for a week. If you happen to have very low symptom burden, you don't fully remove yourself from the world. What we do mean by rest is that if you feel a little bit unwell, take it easy. Don't go continue with physical activity. Don't go for a run right away. Let your body kind of acknowledge the injury, kind of find its steady state, and go from there after about 48 hours. Education is probably the one that doesn't get enough recognition of how important it is. And it's not just education about concussion is a neurometabolic cascade and it causes people to have symptoms. The education is about, what symptoms would you expect to have? Will you potentially be emotional? Will you have sleep difficulties? And what type of sleep difficulties? Some people have to sleep a long time. Some people can't sleep at all. Some people get really sad. Some people get irritable. And then so it's understanding what you should expect in this, so you don't feel like, oh my gosh, is something really, really bad happening. But so that's to what we call normalize the expectations of the symptoms. The other thing is, what to look like as concerning red flags. It's the healthcare professional's role to educate people what to look for in terms of concerning things, whether they need to come back to see someone. I just saw a Q&A pop up right away. Should I answer them along the way here? Is that okay?
Sorry, Michael. You know what? We'll just wait till the end. So why
Okay.
don't you do the presentation, then we'll come back to the questions.
Okay, sure thing.
Thanks.
And so you should find out about red flags and just understand, are there any health concerns or clinical presentations that you should refer back to a clinician? So that's really important. Knowing what type of symptoms you should have, knowing what general recovery should look like, knowing those red flags really helps to settle the individual, giving them a bit of understanding of what their injury is. And I don't think, unfortunately, in a busy clinical world, this one, I don't think clinicians do enough of, to be honest. Respectfully, they are very busy, but when you get to the diagnosis, you get on to the next patient, sometimes that gap of education is cut short, unfortunately. But it's nonetheless a really important piece. So what's unique to athletes in return to athletics? Is it any different than someone that's going back to work? And the answer is yes. And not that they're special or in that, it's just they have different concerns, different kind of things to be aware of. And just like when people are returning to work, there are very important considerations that need to be acknowledged there and for clinicians to understand. The biggest thing for athletes is, when people are usually involved in returning to athletics, sport is associated with their identity. And what I mean by that is they're often known for their athleticism. They're known that it plays an important part of their week. It's who they define themselves. And so when you take them out, if they have a long recovery time, if you take that away from them, that can also cause significant psychological distress and emotional distress. And clinician needs to be aware of how to monitor that and to pivot to making sure that that doesn't kind of go in a negative direction. The other thing about the athletic context is that athletes, generally speaking, are used to being active, and the reality is in returning to athletics and concussion management, really what we do is we take them back to not doing anything, and then we build them up slowly in a progressive way. The reality is that a lot of like athletes don't really love that progressive nature. They like red light, green light, and trying to put the reins on them is sometimes difficult. And so it's just knowing your population and knowing that what they are expected to do or what they want to do is important clinically. And the last one is peer support. Again, that's maybe also tied to identity, but you have to think in often when people are involved in sport, at any level, whether it's recreational now or competitive level, they spend a lot of time with them. And whether it's their friends and families are connected, whether they have to go to practices, training, off ice and maybe in hockey or whatever, off field for other sports, training. It seems to always be going on, additional skills, those things. So that means that their peer group, that support network that they're used to, is potentially fragmented because they're not in that regular kind of flow on a day-to-day basis with their peers. And again, they're recovering from a concussion for sure, but they also have had a key piece of their lifestyle removed from them, their peers, their potential identity, and what they're used to be doing on an everyday basis being active. So hopefully, when you think of from a clinical perspective, clinicians need to be aware of potentially those things that could go sideways, how to manage them, how to educate them are important. So then once we get past that kind of 24 to 48 hours where you kind of want them to settle down, understand what those symptoms are, understand what that recovery maybe look like, you then want to then begin reintegration. And that's the third piece of the generally accepted principles. And that's what I have there as that last one. And reintegration essentially means moving that individual from pretty much that rest period to titrating physical activity in a progressive manner to get them back into whatever respective sport that they're trying to return to, whether it's basketball, volleyball, hockey, whatever that may be. And we'll go through what those progressive stages look like. So here are the guidelines. This is a return to play strategy or return to sport strategy that came out in the most recent consensus statement by the Concussion and Sport Group. And it was, slightly changed from previous years. My point here is there's a lot of text here, and it's, even for people and experts and practitioners, there's a lot to go through here. And so when you translate that into clinical practice and to people that are trying to recover, it's not the easiest thing to do. I'm hopefully you can see my cursor, but let me kind of get everyone's bearings here. And I have hopefully a better slide that will help kind of us understand. What I mean by progressive is that on the left-hand side of the screen, you have, step 1 that moves to step 2 to 3 to 4 to 5 to 6. And when we look at the activity, we are moving from symptom limit activity, aerobic exercise, sport-specific exercise, drills, contact practice, return to sport. And then there's kind of guidelines on what level of heart rate it should be and for how long, and maybe even what modality it should be, and what the goal is of that. And again, I think a lot of good content here, but sometimes hard for either both practitioners, but more likely not patients to really understand. So what I've tried to do here is to create the principles in a more simplified manner. Maybe it works, maybe it doesn't, but let me kind of go through it. First one here is, if we take my example from coming from resting for 48 hours, maybe around 3 days, 4 days after injury, you begin a light aerobic activity. And to be honest, if we look at it back, 15 years ago, we wouldn't start light aerobic activity until symptoms went away. So until my headache went away, your nausea went away. But we realized that kind of mentality didn't work. And so now what we actually do is we actually reintroduce aerobic activity even when symptomatic. But the goal is here is that we don't want to make things too bad. So and so if you kind of go back one slide here, maybe actually I won't go back too much details, but I can talk about it later, maybe in the questions and answers, is you have to have a little bit of tolerance that you can handle a little bit of symptom exacerbation, but not too much, essentially. But nonetheless, you want to have the start of aerobic activity. And really, what's the goal of aerobic activity? Well, it's actually to test the cardiovascular system. It's saying if we raise your heart rate, how does that make you feel? That's really what we're trying to do from a physical kind of capacity level. And what we're doing with that is we want to try to potentially limit head acceleration. So let's say everything goes well, my symptoms don't really change, and I'm able to tolerate aerobic activity, and I'm starting to feel better. Then, well, what do I do next? And what you do next is like, well, if I went for, on a stationary bike, did it for 20 minutes, I seem pretty good, things are improving, and I play soccer. So my next activity may be sport-specific movement. So what are sport-specific movements for soccer? Well, running. So go to a field, you run back and forth, you kind of move kind of these kind of maneuvers that may be relevant to soccer. But again, I've changed not from just cardiovascular perspective, but now I'm moving in a manner from a physical perspective that is very specific to the sport that I'm interested in playing. So let's say those go well. So then you move to sport-specific drills. And so now I've actually added a layer of not just physical components, but cognitive elements. And I'm very intentional in my language here, sport-specific movement to sport-specific drills, because drills have a level of cognitive component to it, whether it's passing with a teammate, whether it's kind of going through cones, whether it's making decisions. So a cognitive level component. And what we're trying to do is add each component one by one, because if we just add everything at once, well, we don't know what's potentially giving the person some trouble. And so what we want to do is do it in a progressive manner. So let's say the sport-specific drills go okay. So I'm able to pass with my teammate. I'm able to run through the cones and do all those things. Then what we do is we go to what's a controlled risk practice. Now the practice is important because we've added the element of sensory. The coach is yelling, the whistle's going, teammates are screaming, the lights are bright, the sun is, in the way. But we also have to know, what are the team strategies? Obviously, what are the physical components? And we're really kind of simulating what we'd expect in a normal soccer game. Now, the controlled risk is really dependent on the sport. And so what you want to do, what we say in controlled risk, is we really don't want a situation that maybe you're heading a free kick right away. So the controlled risk is a situation that we want to limit high risk concussive events. And if that goes well, then you go to the practice, and if practice goes well, you're free after that. And so, my simplified version of the way I explain concussion management is that you try to layer the different components of physical, cognitive, and sensory, like a cake almost, and that by the end of it, you have all the components at the end to hopefully be okay to go back to sport. And so hopefully that gives you a bit of understanding. So maybe, even backing up here, it's like light aerobic activity. Historically, people, what people did is that you had to go on a stationary bike, and that you potentially even, had to do a test to figure out what your exact heart rate would be, and when your symptoms get worse, and then you would take 80% of that. But one of the new actual additions to the consensus statement, if I just go back in time here, is right here, is heart rate, maximal heart rate is 220 minus your age. This is actually, in these two spots, is actually a significant progression in the guidelines, because what it's saying is that you can use sound exercise prescription principles to derive aerobic activity. And actually, some of our research contributed to this, is that historically, we were advising, what you could do with respect to aerobic activity after you went to do an evaluation on a treadmill or on a stationary bike, and the practitioner would figure exactly, how much you can handle. But really, practically, that's very cumbersome to the medical system. So we actually asked the question, well, do we even need that? We have very good exercise prescription principles about heart rate percentages. And we showed that if we just took 220 minus your age and gave them an exercise, a progressive aerobic activity protocol, is that we found that to be very effective in actually making people get better faster. And what we actually advise is that you follow a program for 2 weeks of aerobic activity based on your heart rate progressions from 55% to 70% over the 2 weeks. And we found that those people actually recovered faster doing consistent aerobic activity versus standard of care. And that was published last year, a couple years ago now, in PLOS One, but also made it to its way to the consensus statement, which was really nice to see. So that's one kind of pain point, is trying to understand what aerobic activity is. But I think we're actually getting into a very good place, saying that aerobic activity can be calibrated quite well based on 220 minus your age. And so, very simple math here, 220, if an athlete 20 years old and you want to take, 60% of that, then their working percentage would be 120 beats per minute for that. So that's one thing. Then the other thing we actually asked ourselves is, do we actually even need a stationary bike for aerobic activity? Do we need a treadmill? And this is a question that we had actually prior to COVID, is we were wondering, we know we had evidence that aerobic activity was very good, but we were still restricted to the fact that we had to get people on stationary bikes, we had to get people on treadmills. So we asked the question, does that even matter? And what we wanted to say was, can we actually get people to get moved properly? So from my kinesiology background, knowing that exercise prescription with respect to squats, lunges, arm movements, we could potentially get their heart rate to what an aerobic stimulus, and that potentially may produce very similar responses. So we came up with a term, continuous aerobic resistance exercise protocol, or the acronym of CARE, which is essentially having body weight movements to provoke a general aerobic stimulus. And we actually did this through a mobile device. And we gave them no instructions. We got people to wear an Apple Watch, and we got people to follow these exercises, and they just had at it. And I just want to share these interesting results with you, which I think are interesting. They did, this graph here shows 3 sessions of going through aerobic activity, like a body weight protocol for 20 minutes, squats, all these types of things. This graph here shows the averages of these 3 sessions. So let's kind of focus in on here. The purple band was actually where we wanted them to get to, around 60% of their maximal heart rate based on 220 minus their age. And then we had 5% bounds on each side. And what we noticed here is that, for the most part, half of them, just over half, made it within those bounds. So that's pretty good, But at the same time, actually, a few people were much lower, and some of them were higher. Now we interpreted this to be pretty solid as a reasonable first go at trying to get someone with no background or no monitoring or no coaching just to follow videos to get to that target rate. So that was promising. But the most striking result was all but one person had symptoms improve. And that actually is interesting because that made us, or that makes me question, is it actually the cardiovascular component to actually physical activity, what we know the benefits of physical activity, aerobic activity, brain-derived neurotrophic factors, regulation of blood flow, potentially hormones, all these things? Or is it actually just the fact that they're doing something? Is there some type of like competence, like just being pleased with themselves that they were accomplished something? And I think this shows some support for some physiological component, but it also shows some indication that it's not solely physiological and that there may be other components to how people may improve with the reintroduction of aerobic activity. Now, we don't have the answer to that, but I just nonetheless found it pretty interesting to show that not everyone got within the bounds for what we believe the physiological stimulus to benefit from aerobic activity, but nonetheless, everyone got better, which was quite interesting. Obviously, the reference is here for you to read more, but that's the general synopsis of that paper. Okay, I'm recognizing the time a little bit here, so I'm just going to try to wrap up so we have about 20 minutes for conversation. And the last kind of point here is, well, who to see after a concussion with respect to return to athletics? And my answer to this is that it depends. It depends on where you are in the recovery process, and it depends on potentially your initial symptom burden or your medical history, I think is probably my best response. For those that, if I go backwards in time, for those that have persistent symptoms, so more than a month, I think it's well recognized that those people benefit from seeing a specialist, a multidisciplinary sports team, health professionals that have physio, potentially, access to neuropsychologists, access maybe to kinesiologists, access to an optometrist, neurologist. So that interdisciplinary team's really important for those people in the bucket of persistent symptom. So symptoms more than a month. The subacute phase, I would say, it depends on what your goal is with respect to return to sport. If you're someone that is eager to return to sports and they have intentions to get back to maybe a high risk sport, then going to that specialized environment may be worthwhile. If there's potentially also a high symptom burden or complicated recovery, history, again, that interdisciplinary team may be helpful. If they are generally low symptom burden and they don't feel too bad after injury, and they don't care whether or not they go back to sport relatively quickly, and maybe they're going back to a really low risk sport like tennis, then maybe they don't have to jump into that really specialized clinic right away, and just see if their general health practitioner can give them sound advice and they can kind of go along their own way. So that's very kind of general statements, and I'm happy to kind of dig into that a little bit more. But that's how I would classify these different terms, the different categories. So my goal was to have at least 20 minutes of questions and answers, and I'm at 21 minutes, so I'm going to congratulate myself for that. So I'll turn it back over to Leslie.
Great. Thanks so much, Dr. Hutchison. That was excellent and really interesting. So just a reminder, if you have questions, please enter those into the Q&A. I'm just going to interject quickly, just while those are rolling in. I'm curious on that last study that you were talking about, where you're asking, is this totally physiological, or is there's something else going on?
Yeah.
Did you measure things like mood pre and post, or anything more from a sort of how they were coping or
Yeah,
with their
so
symptoms?
So when we did this original study, it was during COVID, like COVID times, and so that was a little bit more difficult. And we were also still in the proof of concept phase of that. However, we've just finished a follow-up study based on those interesting findings. And so initially, that first study was 2 weeks of using the program, and we just finished doing it for 1 month. And we also did, quality of life, personality, depression, anxiety, pre-post to see how those potentially moderate or mediate the recovery process. And yes, so the answer is I'll have a better answer probably 6 months from now.
Maybe
We
next
just
time.
wrapped up
Yeah.
that study.
Oh, that's really interesting. Thank you. Okay, let's start. So, someone is asking, I was told protocol is to stay away from all screens for 48 hours after a concussion. Are you saying this is no longer true?
Um, yeah, I think I would say it is no longer true to stay away from all screens for 48 hours, and that I think it's relative. So I guess my example is if there is an extreme difficulty with screens initially, then stay away. But if you don't have difficulty with screens, don't remove them from your life. And what you can handle, we often say if you can handle for a few minutes, 5 minutes, 10 minutes, want to read the news, watch TV, catch up on your phone, there has to be this balance. I think there has to be the balance between realistic life and what we are just accustomed to do on an everyday basis and medical management of the injury. And unfortunately, removing these devices, screens, computers, phones completely is significant to someone's just general understanding of how they operate in the world. So it's a significant disruption. Uh,
Okay,
Richard, do you have
thank
anything
you.
to add
Yeah.
to that, maybe?
No, not at all. And those recommendations, like so many in the past, it's encouraging to see the more rational exercise-based things that you've just presented, Michael. Many of the recommendations over the past 25 years have been quite arbitrary. Screens seem bad, and definitely exacerbate symptoms in all sorts of people, but no study was ever done that said everyone should not look at a screen for 48 hours. And there was nothing more than arbitrariness that suggested 48 hours rather than 24 or 72 or 1 week. So if it doesn't cause any worsening of things, it seems to me commonsensical to just um, not view such a thing as a hard and fast rule. It never should have been a hard and fast rule, actually.
Mhm. Yeah.
Great, thank you. Um, oh, I just thought so here's a question with regard to the study. For the aerobic study, was there a control group? Most people improve even without treatment. Were their gains different from people who had no aerobic activity?
I think we're referring to the study was aerobic activity versus usual care, the original one. And so is that in the chat as well? So I can read
It's
the question.
it's in the chat. I'm sorry, I'm going back and forth because there's a couple of things coming in through the chat versus the
Okay.
Q&A. So it's
Okay.
in the chat. Yeah.
So let me just say, I got most of what you said, but I just want to make sure I can understand it correctly. Was there a control group? Yeah, so there was a control group for it, and it was usual care. So one of the actual advantages that we actually suggest in that study was that we did have usual care, and usual care is we want you to exercise. This is coming to the clinic when we tell you to exercise. We give you information about how to exercise. We just don't follow up with you, and so historically, a lot of concussion research has been with respect to aerobic activity is actually getting people to exercise and then getting the other people to stretch or to do something else, which is not truly best practice usual care because we know what the bar has now moved. We know that activity is useful. What we showed in that aerobic activity study is that there's actually value in actually following up with people with compliance and adherence to aerobic activity. And so that was the value add on that study.
Great, thank you. We have another question. Is the CARE app available to others or us if we want to try it? I had a concussion 6 years ago playing rec women's hockey and have struggled ever since. I wanted to return to running, but increasing my heart rate always results in symptoms returning. I miss being able to get a good workout with an elevated heart rate.
Yeah, actually the I said the study is actually complete, but we actually have 5 more spots. So we're sitting at 95 and our goal is 100. And so we do actually have a few more spots for this larger project that we're talking about. And that is a situation, just to give maybe a little bit of information on the study, is we're giving people Whoop bands for a month. And so we measure all their activity, they engage in the program. There's far less we tell people what to do. It's just use the program. And it's kind of what we refer to as a community engagement understanding on it. I don't know how the best way, Leslie, to pass that information on, but I'm happy to share it and to have people.
So if they're interested in the
Yeah.
study, is there like a website?
Yeah.
Or
Okay, here. Why don't you take the
Christian
next? Yeah.
could probably put it into the chat.
Actually, I can probably do it as we talk here.
Okay.
Um,
And you said you had 5 more spots?
yeah,
Yeah.
we're not realistically, we won't turn anyone away,
Yeah.
but we do have 5 more spots. Here it is. Yeah. Let me come back to you guys. And that's in the chat. Where am I? The chat, yeah. So if you want to go to that link there, it gives you an information on how to sign up for the research project.
Great. Okay. Okay. So it's the W, just for those of you, it's in the chat. If you click on the chat, you will see it in there. Okay, great. Thank you. For those with persisting symptoms who eventually recover after several weeks, when would you consider it safe for them to return to gameplay in collision sports? That is, how long is the brain vulnerable for repeat injury?
Richard, you go.
Well, almost every question in this field has no definite answer, but I can start from the position that there is lots of good experimental evidence using different forms of investigations, be it functional MRI studies or diffusion weighted studies or EEG or MEG studies that show concussion-induced changes to persist often long after someone has clinically returned to their baseline based on all of our typical tests. And so there seems to be some pretty good evidence that the physiologic effects on the brain can persist even when someone's functioning is back to normal. If that made any sense, one might think that the brain not having returned entirely to normal would make it less than ideal to return to play in a collision sport and suffer another concussion. But it's really complicated, and some of these tests, if they're very subtle, some of the things I've done, we find that we've seen in a couple of people things don't get back to normal for 4 or 5 years, but the person has felt fine and been doing everything all that period of time. Yeah. So normally we've been going, you watch pro sports and any sort of sport. Once someone is back to their baseline, no symptoms come back, we tend to say, okay, you're good to go. And often that seems to work, but it gets back a little bit too, I think, to what Dr. Hutchison presented at the beginning, that people are different and they come into these concussions with different premorbid scenarios. People with migraine, people with genetic differences that we don't even understand yet will recover differently and at a different speed and potentially to a different extent than others, and we don't always know who those people are. So we make guesses, and it's still kind of the same, that once your symptoms have gone away, you can go back to a collision sport. In the practical setting, I'm always happiest if someone takes, that return to clinical baseline and then adds another month on. I feel most comfortable because I think you feel back to normal before your brain is fully healed. That's not to say that often you just don't get away with it. And I will see pro athletes, and well, they meet all our current criteria, and I'll say, should be good to go. But I'm sort of crossing my fingers at the same time, and I'd feel more comfortable if it would have been the end of the season and they had the summer to recover before they were playing again. That's a lot of talk to say we aren't really quite sure. But if you're not, your financial livelihood isn't dependent on getting back as soon as possible, I'd sort of double the amount of time you were thinking would be reasonable and just make it a little bit later.
Mhm. Yeah, it's a great question. Thank you very much. I'm going back and forth here. I think you should all see the link now. It looks like we um, got a yes on that. We do have someone asking about how to get a copy of the cited studies if you're a regular person with a concussion. I'm not sure, and actually related to that, someone also was asking about a copy of the presentation. So that there will be a copy of the presentation online on the Canadian Concussion Center website, along with the video. And Dr. Hutchison has just indicated that both the studies that he cited are open access, which means that you are able to access those freely. Okay, so here's another good one. For those of us who have years of persistent symptoms who are not athletes, can some form of exercise help? And where can we find information about what that would look like?
Yeah, I think irrespective of concussion, the literature is very solid that physical activity is actually the golden pill for many conditions, and it's a situation whether you want to look at depression, anxiety, stroke, more severe brain injury, concussion. It's there's not been a clinical condition that has not benefited from physical activity, and the heart and the mind, all these things have benefited. So the short answer is it doesn't matter how long you've had these symptoms for, that there is definitely a physiological, psychological, emotional benefit to regular physical activity. And so the question that I think is most relevant to a lot of people is identifying the modality of exercise that you can tolerate, as well as what is the modality of exercise that's going to give you the best chance to integrate into your lifestyle in the big picture. I think is often the most challenge. And when I try to help people from a concussion, I realize that riding a stationary bike is not in a clinic is not the ideal situation for years to come. So it's trying to identify what they like to do, what their capacities. To get this maybe not too much more complicated, but you need an understanding of like what their goals are, what their demands in life are, and what their capacity is. And then you got to find that kind of balance between their capacity and demands in understanding what the best exercise prescription for that is. But 100% that you just need to figure out what the modality of exercise is, not if a modality of exercise is important.
Great, thank you. A few more questions just around the research. Someone is asking, is the RIA app available now to help people? I understand that there was some research being done to improve it.
Yeah, so we're still in the modality of doing the research. I'm directing everyone into the research arm to use at this point, because as the person correctly stated, is that the goal was in the last little bit to have this community engagement to improve the app. Nonetheless, we've seen some positive results, but part of this is also to getting engaged in the community, understand what people want to see, how do we make it better, with the goal of obviously making something better for everyone.
Okay, great, thank you. And then we had someone asking, are there more studies coming that people can participate in? And another one asking, do you have to be in Toronto to participate? So we have someone from PEI.
Okay, so no, you don't. So yeah, all comers are good. In geographic location, that's one of the goals of, I think, of many people's research programs, is not to have borders with respect to that. So yes, that's good. If you are in the city, we have multiple studies ongoing, and I'm sure just like UHN. So I don't know if it's the best format to get into those things here, but I think the reality is, reaching out to Leslie, Richard, or myself, is that there are a lot. Toronto's very much known as a concussion center for research, and I think there's a lot of opportunities for people, to be quite honest. So the short answer is yes. It's just figuring out what's probably the best one for them.
Okay, great, thank you. Marco's asking, with the implication that mental health and mood are tied to the recovery process, rather than just the physiological aspect, do you think adding simple sports specific movements into recovery earlier may be beneficial, such as just taking hockey shots or stick handling?
Yeah, I think it's a very good point they're bringing up, and I think that was part of the motivation for actually our care protocol, is because what we realize is that not a lot of people love hopping on a stationary bike or a treadmill, and what we wanted to do with that is identify what we call common movement patterns, squats, lunges, all these things that mimic and are required for all sports. And yes, you can add a component of stick handling, those things for sport specific, as long as they're not too complex from a cognitive perspective, or they're not too much from a sensory component. If you go back to my kind of titration of sensory cognition, a lot of things that stick handling, for athletes, is not that hard. That's not actually not a cognitive task for them at all. It's actually just muscle memory, and they don't even have to actually really think about it. So that, I think, is completely reasonable for sure. And maybe just to add to this point about not having people not to be too afraid of like squats and lunges and these movement patterns, is sometimes we'll get people in the clinic being like, I don't think I can do that. I get symptoms from it, and I'm worried about all the squats and stuff. And I said, well, you're here today, and you've probably done about 30 squats before you got here. You got out of your bed, sat coffee, tea, you got in the car, you got out of the car, you sat in the waiting room, you came up. So you've probably already done 30 squats before we even started chatting today. And so it's just understanding, making the connection between going back to what are your demands, what's your goals, where are you trying to get to, and just highlighting or identifying what actually your capacities are. And the quicker, I believe, the quicker we get back to common movement patterns that we as humans are always used to, whether it's bending down to get something, hinging, whether it's pushing something, doors open, pulling something, these are all necessary movement patterns of way of life. And if we can introduce that in the rehab process, I think we're making progress to having people be, it becomes more common to what they expect normal life to be.
That's great. Thanks so much. I know we are really close to time, but I'm just going to try and get in a couple more. We did have a question. I've heard this one before. Is there damage being done if you have an elevation of symptoms with activity? I think sometimes people fear that they're doing more harm.
Richard, do you want to take this one?
I'm just looking at the Q&A, and it starts off with, I've read contradictory opinions, and I think the key word there is opinions. And lots of people have one. I am unconvinced personally that we really know. And I wonder myself, I could have asked the question myself. Am I hampering the recovery process by pushing myself to the point where symptoms come back, which is kind of the same thing as am I doing damage? Well, it's a little bit different. One is just you're slowing recovery. The other is making it harder to recover. Or does it really make no difference? Just, I exercised a lot, so I've got, some lactic acid buildup. I feel that it was time to stop. I had to give up, and that just the body washes it out, and you're back to normal, and you know what your threshold is there, and then you go through. I don't know the answer. I don't think there's all sorts of overconfident doctors who will say one thing or another and say that you're doing damage. I'm not really sure. I think you can definitely do damage if you get another concussion. I'm pretty confident about that while you are still symptomatic from a previous injury. Whether or not you push yourself, whether or not pushing yourself just far enough to bring symptoms on to know how far you can get is doing any damage, I am not convinced of that. And my own personal thing is that I would personally have no fear in doing that. I would do that to know where I could get to and then pull back a bit. And the body is an amazing thing, and all sorts of changes go on in response to all sorts of things that it confronts both externally and internally. And I would think if you've just got to the level of reproducing symptoms, I would be confident the body would be able to recover back to where you were and then just, give it a little rest for a while. But that's an opinion.
Okay, thank you so much. Okay, are you willing to do one more question?
I'm good to keep
We've got,
going.
you're
Yeah,
okay?
I'm
Okay.
good to keep going.
We've got someone from Edmonton. My husband has had post-concussion syndrome for 2.5 years and is still experiencing symptoms, especially fatigue. Sometimes he sleeps poorly and wakes up with bags under his eyes. He's seen a neurooptometrist, neuropsychologist, physiotherapist, and is seeing a speech language pathologist. Well, we've seen a sleep specialist. They were not a concussion expert. Can you recommend any other specialists that he should see? This comes from Allison.
Yeah, I read the thing. It's specialty types, for example, I guess is what the question is referring to. The maybe in the question is one of the things you could see a concussion or post-concussion syndrome specialist who would perhaps have a slightly different take on this. As Dr. Hutchison said at the beginning, he thought, people who had long-lasting symptoms probably should be seen by a specialized team just because they see it a lot. Having said that, any one of the number of people your husband has seen already might have happened to know as much about concussion as anyone else and could have done something. But if relief hasn't come, seeing someone who's expert in concussion, and there has to be someone in Edmonton. I mean, it's a pretty big city and one of Canada's biggest provinces, and it's kind of a sports city too. There must be someone in Edmonton or some clinic there, presumably, especially at the university hospitals there. When it's been that long, concussion specialists and other physicians would usually recommend treating symptoms with the same sort of medications or non-medical therapies that are used for that particular symptom, even if not related to a previous concussion. So fatigue can be treated in many ways, with different drugs or sleep hygiene things. It's what most concussion specialists would try, or at least have the discussion. Do you want to try this and for a little bit and see how it goes? And uh,
Okay.
I don't know
I
if
know
that's
Calgary
go
is
ahead, Michael.
not that close to Edmonton, but Calgary is the University of Calgary is a world-renowned concussion center, for sure.
Yes, yeah. I mean, there should be individuals who are just as
Yeah,
good in Edmonton, but for institutional expertise, the University of Calgary has had for a long time a very well developed concussion research and clinical focus for sure.
and they may be able to direct you to their individuals in Edmonton. They probably
Yeah,
know better
yeah.
than we would.
Great. Thank you so much. Okay, well, we've gone well over time, so I just want to thank you. And there are a couple of thank yous in the chat. Someone has thanked you so much for your expertise and knowledge. I am much less frustrated with my concussion than I was an hour ago. So that's really good to hear. And thank you from a former hockey player who said concussions were always the most feared injury because of the thought of the dark room treatment. And it's a relief to hear, oh, I'm losing it here, of a more active approach, getting athletes back to sport movements faster. So thank you so much. Really interesting presentation and Q&A session. Just a quick reminder, if you can fill out our survey that will be coming to you, it's in the chat, but it will also be sent to you as well. And Christian has again put the link in for where you can access all of the presentations and videos. So thank you again, Doctors Hutchison and Wenberg. And thanks everyone for attending. Have a great night.
Thank you.
Bye.
Carry on.
Bye.